Great, good afternoon, and welcome to those who are not with us this morning, and welcome back to those who were. I'm moderating today's session on criminal justice and behavioral health. My name is Jenny Simpson, and I am the Office of Behavioral Health, Equity, and Justice at the Substance Abuse and Mental Health Services Administration. We are a federal agency within the U.S. Department of Health and Human Services. So this is the final workshop in today's series. Earlier, you heard about screening and assessment in the criminal justice system. You heard about high utilizers and meeting those complex needs. And in this workshop, you're going to hear from colleagues who are demonstrating the value and impact of connecting people to treatment and services. Establishing effective connection between linkages to housing, to social services, to human services, behavioral health treatment, healthcare. We all know those are incredibly important things to make sure that we improve behavioral health outcomes, criminal justice outcomes, social outcomes for those with the highest needs in our systems. It also improves how we use resources and also improves how we administer justice and improve public safety. So as we begin, before we start, please silence your cell phones. We don't hear those during the presentations. And after the workshop, remember to fill out the workshop evaluation. We will have a Q&A at the end, so please save your questions until then. We've allowed at least 10 minutes for that. So I'm going to introduce our great speakers today. First, we will have Commissioner Pat Farr from Lane County, Oregon. He has been in the position since 2013 and previously was a member of the Oregon House of Representatives. In addition to his legislative work, Commissioner Farr served as a Eugene City Councilor for 8 years. During his time as a councilor, he served on various committees, including one on affordable housing, but most notably, he served as the chairman for the Council Committee on Homelessness and Youth. Next, we'll have Dr. Chad Koyanagi. Dr. Koyanagi is a Honolulu-based community psychiatrist. Currently, Honolulu has the highest per capita rate of homelessness in the nation. He works for the Institute for Human Services, which is the largest homeless service provider in the state of Hawaii, and uses his position and his expertise in the chronically homeless population to connect and work closely with Honolulu Police Department. In addition, he also does inpatient and emergency psychiatry at Adventist Health Castle Hospital and has provided psychiatric services at the Honolulu Jail and Prison. After Dr. Koyanagi, we have Chief Judge Maxine Aldridge White. In 2015, Chief Judge White was appointed by the Supreme Court to lead Wisconsin's largest judicial district and serves as the administrative chief of the 1st Judicial Administrative District, which is comprised of Milwaukee County. Prior to joining the bench, she was a federal prosecutor in Wisconsin. Finally, to conclude our presentation, we have Stephanie Garbo. Ms. Garbo serves as the Judicial Operations Manager for Milwaukee County Combined Courts. In this role, she oversees the adult pretrial supervision and specialty court operations, including diversion, deferred prosecutions, and drug treatment court programs, and serves as the liaison between the courts and service providers. I'll hand it over first to Commissioner Farr.
Thank you, Dr. Simpson. My name is Pat Farr. I'm a Lane County Commissioner, Lane County, Oregon. Big city is Eugene. Go Ducks. I am in some pretty heady company this morning. Last night I was at the Grand Ole Opry, and the headliner was Kathy Mattea. Prior to Kathy Mattea, a number of first-timers were up there, and I feel like I'm with headliners, and here I am, your first-timer, first time on stage. So bear with me as I go through a small county's role, or a small county's work on jail diversion programs. I'm going to talk about a pilot program that uses data to identify a specific target population of high-cost and high-need individuals who are frequent users of multiple systems, including jails, homeless shelters, emergency rooms, and whose persistent cycling illustrates the failure of traditional approaches to the system. We've all heard of $1 Million Marvin. Everybody's heard of $1 Million Marvin, and that's a kind of a hackneyed old story about the one individual who cost $1 million. Well, $1 Million Marvins exist everywhere, and it's not just $1 million. Some Marvins are far more than $1 million, but some Marvins only cost us $100,000, and some Marvins, or Excuse me, it's not Marvin, is it? So, Mervyn, thank you. Some only cost us a few $1,000s, but in fact, they are costing the system as well as the human equity involved. So I'm going to talk about Lane County's Frequent User System Engagement Program. And is this my click?
Yes.
There we go. Lane County's Frequent User System Engagement Program. What we're identifying is a need for building supportive housing to solidify our jail diversion efforts. Supportive housing includes an array of services, and not just substance treatment and not just mental health services, but it also involves schools and not just education, but job placement and a number of different services that really are a part of residential services in supportive housing. It also isn't gender specific, it's not age specific, and it's not ethnicity specific. Everybody can be involved in a need for supportive housing. In Lane County, we employ a CSH system. It's called Frequent User System Engagement. I'm going to show you here a couple of pictures of various sites. There we go. This is unsanctioned housing. We're all familiar with unsanctioned housing. Sanctioned camping that we allow in Eugene, very base level living conditions. A dusk to dawn shelter program where men and women can sleep at night but have to go someplace else during the day. It's just a place to get a meal and a bed. This is a church. Actually, my church is the Lutheran Church in Northwest Eugene that allows camping through a sanctioned program in its parking lot. We do allow several hundred different sites throughout the cities. We are involved in building modular shelters. Clackamas County and Lane County are working together on different forms. This takes place in Clackamas County. Next is this is Opportunity Village in Eugene, which is transitional housing. This is housing that does not involve plumbing or electricity. It's just a place for people to lock the door at night and have a shelter over their head. And then this is permanent housing, tiny houses. We're all working with tiny houses. These are 200 to 300 square foot houses that are currently in the final stages of being built in Eugene. This also allows for equity building. So what I'm going through is a continuum of housing types. Section 8 housing, we are involved in partnerships, multiple partnerships. And also, once again, it's not just adults that need housing. A growing number of kids, school-age kids, need housing. Our FUSE model involves system collaboration, and adding that with stable housing and support services, we get better outcomes with reduced efficiencies and increased cost savings. Now, what that means is that we have to work closely with the public safety system, with the police, with the criminal justice system, and also with nonprofits and hospitals to identify the people who are the most frequent users of the systems that cost so much money. Our community partners in Lane County are broad. You'll see on this list here a few logos, including our cities, including our hospitals, including our health care plans, and including the police department, the sheriff's department, and the DA's department. And this is a slide showing a collaboration between the city, state, county, and federal work. You'll notice, you probably don't know Congressman DeFazio, local mayor, Mayor Piercy, and Mayor Lundberg, and I'm in the picture there. We're working together on housing solutions. Developing the FUSE list, excuse me, we'll go to the pilot project. I'm going to talk about our pilot project. The first year that we engaged this was in 2016. We began a pilot project where we had identified a small number of individuals who are most frequently using the criminal justice system, the police system, the emergency rooms in particular, or they're being kicked out of the library, or they're being kicked off the buses, or they're being barred from homeless shelters. That's how the people that we identify. And we achieve it by engaging in street outreach, by putting people on the street. Now, we have to conform with CFR 42 rules and HIPAA rules. We cannot dig into hospital records to see who's getting treatment and what kind of treatment they're getting. So we have to be creative about identifying who the users are. So we developed the FUSE list by using this list of data points, police services, court services. I won't go down the entire list. And if you'd like to have this PowerPoint presentation, just leave a note and we'll get that to you. It includes inpatient hospital, NICE, emergency departments, intakes at the jail, shelters, and so on down the list, including being banned from a number of services that homeless people typically would access. Our through this process, we identified our top 100 FUES, frequent user clients. And if you look on here, the numbers that are shown here, 73% of the people are high healthcare users. Now, this is across. Many of the identified individuals have used crossover services. 88% had frequent arrests, 30% frequent court citations, 52% actual frequent jail stays, banned from emergency shelters, and bus bans. Now, in our finding highlights, I'm just jumping to the conclusion here very quickly, so I'm going to skip past this slide, but I'll talk more about this. These are some of the results that we achieved through identifying the most frequent users of our system. And you'll see that police arrests were down 82% after the first year among the test group. Court citations down 75%. Healthcare costs, including healthcare costs in general, down 53%, and the utilization of emergency rooms were down 26%. Everybody loves those numbers, and the FUSE program that we used cost a relatively small amount of money. It cost less than $100,000 to put this program in place for a very small target once again. I'll give you a disclaimer at the end of my presentation on the size of the target and the size of our county and the size of our cities. But you can see the numbers are pretty startling. In fact, they're startling enough to the point that once we completed the first year of people are lining up to help us expand the program, including federal grants, including local grants from hospitals and from our healthcare agencies. Our evaluation method, we use a pre-engagement process and a post-engagement to develop the numbers. We look at the data before and after the intervention to identify changes in utilization. We look at changes in hospital and criminal justice involvement, and we also conducted interviews with a small number of the people involved to determine what made this program work for them. In the pilot, we identified through street outreach, we enrolled 26 people in the actual street outreach. That means of the 100 people that we engaged or we identified, 26 of them we actively worked with throughout the entire length of the pilot program to determine what course has been charted throughout the year of the pilot program. And of those in street outreach, 11 participated in the 11 were actually placed in housing. Now I'll stop here for a second and talk about that. The most critical element of this program is making certain that the people who are utilizing the services are placed in stable, supportive housing. Without stable, supportive housing, we're not able to do anything. That is my opinion, and it's borne out in fact throughout the length of the pilot program. And supportive housing, once again, is for people who are accessing the emergency services most frequently. And it's not just mental health, and it's not just substance use, but it is largely mental health and substance use. Sometimes it's kids in school who are homeless, who need supportive housing in order to stay in school. Sometimes it's people with gender identity issues who need supportive housing to make certain that they're not bullied or mistreated in less than stable housing. 11 were placed into housing, and since the end of the pilot, which ended a couple of months ago, 7 more have been placed into housing. So a total of 18 have been placed into housing. You'll look now at our criminal justice findings. The first bar you see there is the Eugene Police Department arrests, down 82% in the test group. You love those numbers. The jail intakes down 50%, and citations are down 75%. You'll see they're small numbers. Lane County is a small county, and this is a pilot program. I'll give you that disclaimer several times, but we are confident as we move into the new year with a far more robust program, we're going to see the same numbers as we progress. Our healthcare findings are pretty startling also. We would like to see prescriptions up. We'd like to see people getting the medications that they need, and in fact, prescriptions were up. And as we go down the list, emergency room visits, emergency department visits down 26%, behavioral health down 14%, and the cost among the individuals per individual served was down 53%. The cost of the services that they accessed was down 53%. All good numbers. Now, when we interviewed the folks afterward, we said, well, why did this work for you? Why did getting into a house make it so that you were able to access the services that you need? Made it so that you were able to access alcohol diversion, make sure you're able to access the medications that you need, and not being freezing outside and being in an apartment. Now imagine that. We have people who are trying to stabilize their life, whether they are using substances or whether they have behavioral health issues, mental health issues, and they've been discharged from a state hospital, that they're trying to stabilize their life without stable housing. Well, it's simply not working. The traditional approach is not working. Another statement is, every day is a survival mode. You get unhealthy out there on the streets. Well, that is certainly an understatement. Now, you think about if you've ever had a sore on your foot and you treat it with the treatment so you're able to treat your sore foot at home. Imagine being on the street. Imagine being in freezing and wet conditions where that just exacerbates, gets worse and worse and worse until that's all that you can think about. So now I'll talk about the limitations to the evaluation. This is a small pilot in a short time span, and our pre-post method doesn't involve a randomized control trial. This is raw numbers that we have experienced with a pilot program. And since that pilot program, we've had a number of people step up to the plate. We've had a My Memorial grant. We've also had a HUD grant that is going to, both between the two, are going to allow us 25 more housing units this coming year for the next phase of the program. So the next steps, now this is the most important part, is once we've got all this information, how do we make the most use of the information? Well, we're going to continue our evaluation efforts. We're going to expand the program, and we're going to add more permanent supportive housing. Once again, that's the key, is permanent supportive housing. We just recently got a $200,000 commitment from our coordinated care organization, which is a Centene company. It's Trillium, which does our Medicaid billing in Lane County. And we just solidified the funding for a 50-unit county-operated Housing First building on county property. A Housing First building will be admitted to people who have been identified through the FUSE program, and it will allow them access to the services that otherwise it's questionable as to whether or not they'd be able to receive the services. That is a picture of our new facility. We'll be breaking ground this fall. The facility on the right, the one without windows, is our behavioral health facility. The adjacency to our behavioral health facility is critical in this situation. The one on the left is a 50 apartment, not beds, but a 50 apartment complex for people with substance use issues, with mental health issues, with active substance use issues. And these apartments will have beds, sinks, kitchens, just like a regular small studio apartment. And the final thing I'll leave you with is something for us all to think about. You all know It's a Wonderful Life. Well, in It's a Wonderful Life, James Stewart talks to Mr. Potter, and he says, remember, the rabble that you're talking about are the people who do most of the living and dying in this community. Is it too much to ask that they live and die in a comfortable room and a bath? I think not. Thank you.
Good afternoon, everybody. I am Chad Koyanagi from the County of Honolulu. So, as you heard earlier, we have, of all the states, we have the highest per capita rate of homelessness in the country. I believe DC has a higher rate of homelessness than the city of Honolulu. This problem is so complex, and so many factors play into how we've gotten to this position, and so many agencies need to step up and coordinate different services together to help address the problem. And so I'm going to just touch upon some of the initiatives that some of the agencies that I've worked with have been undertaking. And I'm not going to talk so much about housing per se, which is, of course, one of the major reasons why we have a homelessness problem. So we have approximately 5,000 or more unsheltered homeless on Oahu alone, of which maybe about over 1,000 are from Kofa, Micronesia, Marshall Islands, and Palau. So many factors have resulted in why we're here today. Of course, we don't have adequate low-cost housing. Another reason is the state mental health system is fragmented, and difficult for many of our folks to get access to the right kinds of mental health and substance abuse treatment. As far as the criminal justice system, we have a jail on Oahu, which a lot of our homeless folks end up cycling through. And one of the issues, as we all know, with jails, people coming out on the back end tend to come out at unpredictable times with difficult, complex needs, and many of them lose their Medicaid coverage when they're in the system for more than a month or so. And so trying to get them back into the system and back on their benefits is a huge thing. And the state of Hawaii, Department of Health, the Department of Medicaid is trying to collaborate with the prison system to get people back on Medicaid as soon as possible after coming out of jail. Oops. We also have a huge methamphetamine epidemic, probably one of the worst in the country. The opioid epidemic, of course, is affecting our population, but not to the extent of the methamphetamine epidemic. I believe in the criminal justice system, I think over 2/3 of the inmates who are tested for illegal drugs are test positive for methamphetamine. Our island geography creates difficult problems too. A lot of folks who come to Hawaii on one-way tickets, assuming that they're going to restart their life and be in paradise, are sadly awakened to see that there's very little housing, the shelter system is very sparse, and get very easily caught into deciding that they made a wrong decision coming to Hawaii for help. So for more words about the mental health system, our state hospital, like many other state hospitals, is only takes forensic patients. So there are a lot of folks who used to be institutionalized and people who would benefit from high-end outpatient services like assertive community treatment teams, which used to exist 10 years ago, but our state did away with that program, and so there's a big gap between people who are very severely ill and need longer-term care and people who are able to access appropriate intensive outpatient services. And so a lot of these folks fall through the cracks, and a lot of these people end up being kind of gravely ill and chronically homeless. We have a lot of this population ends up bouncing back and forth between the two psychiatric hospitals on Oahu, and jail and cell block and arrest and ERs. And they cost the system quite a bit of money. Also in our state, we have difficult problem with the system is very civil rights to the point where people who are gravely ill and lying on the sidewalk in their feces, and those folks are not allowed to be given the help that they need to have a meaningful life. And we have a current case that we're trying to pass a case for a recent law, which is we have an assisted community treatment law, which is based on Kendra's law in New York, and we just recently passed it. And I was one of the first ones to try a case, and just going through the courts and experiencing the objections from the public defender was very, very discouraging. So we had to go back 4 or 5 times based on all of these continuances, and it's clear that this gravely ill, non-violent population has very difficult time accessing care. So of course, in addition to the need for permanent low-cost housing, the agency that I work for has started a bunch of programs to put into place transitional specialized housing for people who have various healthcare needs, behavioral health and addiction. One is we have a regular emergency shelter one for single men, and another one 2 blocks away that's for families and children. So most of the folks are referred to those shelters, and we have a couple of other agencies that have emergency shelters too. But then we also have a medical respite for people who are homeless, and they go into the major hospitals, and they have severe cellulitis of their legs, and they need to be on IV antibiotics for a couple of weeks or months. And so those folks go to our medical respite home called Tutu Burt's House, and they end up saving the hospital quite a bit of money because you don't have to keep them in acute care settings, and you can discharge them to these medical respite homes. We also have a vet's home. We have a house that targets people who have addictive issues. It's like a detox house where people stay average of a month and a half. And as the numbers show, that about a third end up going back to their regular shelter. About a quarter of the folks who go through end up going into permanent housing. And another quarter of them go back to their previous homeless life. And then the numbers for the medical respite home, Queens Medical Center, which is the biggest hospital in Hawaii, which has assumed most of the brunt of the economic effect of chronically homeless folks, that has been an economic sponsor of this program, and they've reaped the benefits from having a place like this where they could discharge people, maybe 2 months ahead of needing to stay in the hospital the entire duration of getting IV antibiotics or subacute care. And similar to the other numbers, about a third end up going to the regular shelter after their stay at Tutu Bird's house. About a quarter went into permanent housing, and then about a quarter went back to their homeless life. Then recently, this is a collaboration with Honolulu Police as well as multiple outreach agencies. The police had a beautiful unused space in downtown Honolulu where a lot of the homeless, drug addicted, or mentally ill people kind of congregate. So they gave it this space where multiple agencies now have a beautiful drop-in urgent care center where people who are severely mentally ill or using drugs can come in for dressing changes, to engage with outreach workers, to get benefits signed up, get other treatment referrals. Also offered medication-assisted treatment for addictive disorders such as buprenorphine. And it's been my experience. It's been a really amazing place for. We have some severely mentally ill schizophrenic folks who happen to just stroll by the clinic, and the rapidity at which we're able to get these people on medications is far quicker than if we were doing traditional street outreach, which may take months or years to get the same person engaged with treatment providers like myself or on long-acting injectable medications. Alluding to the previous talk, various health provider agencies also keep track of people who are frequent utilizers of services, either ER visits, hospitalizations, or arrests. And so one of the programs that we have is a homeless intensive case management team, which is funded by the state, in which people who have 3 or more acute care visits to hospitals or 3 or more what they call MH1s. MH1 is a police transport of someone who's behaving dangerously in the community to one of our ERs. So if they have 3 of either of these types of episodes, they get referred to our program. And then, so we've had 80 people in the past year entered this program, of which most of them became engaged with their case managers and had access to the care that they needed. And we've noticed that the arrest rate as well as the visits to ER settings has gone down dramatically. Further collaborations with the police. So about 10 months ago, Lieutenant Lambert, who's now Captain Lambert at Honolulu Police, came to us and wanted to start a program called HELP, which is a joint outreach between plainclothes police officers and various outreach workers from several of the agencies that do this kind of work. And so for the past 6 or 7 months, we've been going out once or twice a month, sometimes on night outreach, which is fascinating. And we go out with the officers. Sometimes they're in uniform as well. And the goals are multiple-fold. One is to help the police have a friendlier appearance to the homeless folks who usually don't trust them. To help train up some of the officers as far as how to engage mentally ill or drug-addicted folks, and also to collaborate on initiatives such as they have coordinated sweeps at times where if any of you have been to Honolulu recently, there's so many unsheltered homeless that there are certain neighborhoods that have just, the sidewalks are just filled with tents, and parks are just filled with homeless people. Sometimes they affect businesses and affect kind of safety of certain areas, and sometimes we have these coordinated sweeps that are collaborations between the state and the city. And before those sweeps, we usually like to go out with the police and offer these people alternatives to, just getting shifted off to some other part of town, and giving them also all the referrals that they possibly could use. They also have access to the community outreach court, which helps people who are homeless, who have minor bench warrants for things like illegal camping or unpaid parking tickets, and these people can resolve their bench warrants in the community, in the parks sometimes, just so that they can be eligible for permanent housing programs going forward, and also to get things like IDs. A new project which is about to start in Honolulu is called a LEAD project. It's based on a Seattle pre-booking diversion program for people who are arrested with fairly minor crimes, and at the point of being apprehended, if the officer identifies one of these people as having a mental health or substance abuse need, then they'll call one of the workers and have access to detox or hospitalization or treatment referrals immediately within half an hour or so, and instead of incarceration. There's approximately 30 agencies that have bought into this project, and the Seattle data shows that this program has great promise. So this last slide is probably what's very dear to me, doing street outreach. The guy sitting on the right is Justin Phillips. He's my partner. He's an outreach worker who's a former felon and drug addict, who's probably the most amazing person who's turned his life around to become the most amazing homeless outreach worker. So he and I and other people of the team go out. They go out almost every day during the week. I go out with them once or twice a week. And the goal is to provide homeless outreach, as well as access to medications, access to other treatment programs. And each time we see a particular person, our goal is to assess their readiness for change on every encounter. We've had some amazing success stories with even fairly, we've had some schizophrenic patients who have been untreated and homeless for 20 or 30 years who we're able to get on long-acting injectable medications and off the streets and into permanent housing. They also do like dressing changes if we have the nurse with us. A lot of the folks in the community who are homeless already have case managers through other agencies, and we also try to link them with those services too. One of the news stations in our community, Hawaii News Now, made a 30-minute documentary on our team. Welcome you to watch it. It's called Prescribing Hope. You can find it on the internet, or if you go on YouTube, it's a 30-minute documentary which is so well done. The producers recently got an Emmy Award for their work. Let's see. And another collaboration with the police. I was speaking with Captain Lambert the other day. He is meeting with, I believe, some consultants for the Department of Justice, and we're considering looking into a CIT model for Honolulu Police. So the CIT is the Memphis model for running a police program that trains officers on how to deal with mental health emergencies for people who are mentally unstable, and teaching officers how to work with people who are in crisis, and having a specialized group of officers who are designated to be working in that CIT group. So Maui had a current iteration of that, which has been very successful, and so hopefully Honolulu can do a CIT model as well. So I guess so just to summarize, the enormous impact of homelessness on our community and its tremendous amount of work and coordination of care that needs to happen between various agencies. Homelessness is probably the #1 problem in our community, except when we're having false missile alerts. But hopefully, excited to think of the possibilities. We found recent reductions in our numbers for homelessness, for homeless people on our island, but I think that's a distorted number because all the folks who are most easiest to house are probably in housing already, and all the people who are left are the ones that are either most difficult to engage or the ones who are resist efforts and outreach efforts to assist them in permanent housing. And so I think the numbers, we get a distilled version of the homeless folks now. And the work is going to be even more challenging to figure out how to address the most refractory, difficult individuals. Thanks.
Why don't we just leave Hawaii up? I want to thank the council, NACo, for inviting Milwaukee to be part of this very rich program. We are so happy to be here. I'm in the little corner in the box. I'm going to talk about the council that we have in Milwaukee County. I'm just a pip for Ms. Garbo, who is, you know, the other part of Gladys Knight and the pip. As the chief judge in Milwaukee County, I can't tell you how happy I am to be part of a team that has attracted a lot of resources and opportunities for the people in Milwaukee County. There are 72 counties in Wisconsin. We're the largest. We have the people, and the other chief judges, I tell them, they have the land. We have a population of nearly 1 million. I think it's been reduced by the fact that I'm hearing around Tennessee that you all took the rest of them. As in other communities, a significant number of our population is Caucasian, and the majority of our prison and city population is African American, Latino, or other minorities, or those who are poor, who've suffered a lot of trauma and end up in a lot of criminal justice systems because of those factors. We have an incarcerated population that's dropped nearly half over the last 10 years. Pre-trial, this is our pre-trial population, and it's below 1,900 in our local jail now. It used to be akin to 4 running towards 5,000 when I started as a judge 25 years ago. When I first became a judge in '92, I met the Honorable Janet Reno. She had money, and she invited some judges to Washington, D.C. to talk about a drug treatment court. I wondered why the chief judge at that time handed me the plane ticket to go to D.C. When I got there, I learned what the process was like. I got back home to Milwaukee, and I described the process to the chief judge at the time, and he said, go for it. We applied for a grant. We got $500,000 to open a drug treatment court. Why am I talking about this now? It's because I was nearly bludgeoned by my colleagues. We're not probation officers. We're judges. We wear robes. The DA said, I'm not a nurse. The public defender said, not my client. It wasn't the season for the reasons that we're here today. We're here today because we've learned better about what criminal justice and justice really is all about. It's about tearing down those silos, those walls, and finding a way to really get to the business of the people, of ultimately making us safer in our communities. So in order to establish public safety in the Milwaukee community, we learned the hard way. In about 2007, after a lawsuit, we found ourselves in the throes of my old bosses in the U.S. Attorney's Office, asking us to either solve our jail problem or they want to take it over for us. We decided to solve our own problem. And one of the mediation points, with the support of technical assistance, we decided on a lot of different things, and one of them was to come together better and become really what the community expected. To have the chief judge, the sheriff, the DAs, the public defenders, the city attorneys, the mayors, the Department of Corrections, and everyone work together on solving the public safety issue in Milwaukee County. So our county board came up with a resolution, which became more than just a resolution on paper. It really is a statement about how life should be lived in an American city. The purpose of the council is to function as an independent entity governed by key justice system leaders, including those that I've already named, empowering us to define the broad justice system goals, monitor, analyze justice system performance, and facilitate collaborations in a real meaningful way. We are governed, the council, by an executive committee. Everybody brings their badges and their badges and their badges and shows the power that we have individually and independently. And what we do is we set aside those things that we can to come together on issues. The example that Stephanie Garbo will talk about is one that goes beyond just getting the okay of a DA or a police chief or a mayor or even the governor. It's a collaboration that resulted in us finding resources to well, I think we built our own little agency together. I don't know who the leader of it is, but we built it together. The executive committee is chaired by the chief judge. One of the reasons why I think they picked me, other than the loud voice, because we're all getting old and can't hear that well, is because the chief judge in Wisconsin is appointed by the Supreme Court, and we don't run on party politics, no matter what you hear across the land. I am a nonpartisan elected judge in the county, along with the other 47 judges in Milwaukee County. The DA is a partisan office. The sheriff is a partisan office. So I think they found an office where we don't get elected based on our Facebook page of having been at a conference like this. We get elected based on our performance on the bench without regard to politics, and politics can take our robes away. So the executive committee meets once a month in my chambers, in my conference room. We all sit down and we talk amongst ourselves about things that are ailing us. We don't talk about ourselves on the streets when something bad happens to one of us. We operate with civility because we know even if we perform well, if we don't have good relationships, that story can be told in many different ways. So the executive committee has a lot of respect in the county and across the land because we operate with the chief judge as chair, the public defender is the co-chair, who is also a nonpartisan position. We meet with the community at least every other month to tell them what we're doing and why we're doing it. I'll give you one example of something we did before Stephanie takes the microphone. We have applied for grants from everybody who will listen to us. Because even though the county gives me about $40 million to run the general jurisdiction courts and to support the 19 municipal courts and everything that happens in the system in Milwaukee County, it's not enough. It's just a drop in the bucket. So since the council has been established, we've gone after every opportunity possible. This could not be possible if we were not operating with the county exec as our fiscal agent, and I sign on the line with him, getting the resources we need to run the project. One of the latest grants that we were fortunate in securing was from MacArthur Foundation, and that's when we got the idea, if we can't get the seriously mentally ill out of jail through our normal silos, why don't we build an agency that's separate from us, but made by us to take care of it? Stephanie will tell you what it's like. Shh.
So as the chief mentioned, we started out to build a post-booking, what we were calling post-booking stabilization, and it's pretty much a new entity with the key leaders listed below that we knew we would need at the table to make this successful. So prior to applying for the MacArthur Safety and Justice Challenge Grant, just to give you a foundation of what we were already working with, we had an extensive universal screening process, which is a 24-hour, 7-day-a-week, 365 pretrial screening in the jail. So everyone booked into our criminal justice facility on a bailable offense has a pretrial assessment. We switched in 2016 to the public safety assessment. Our screens also include an interview, which at the time included the UNCOPE for substance abuse and the LSIR SV for early intervention determination. We also had an extensive early intervention program. So in Milwaukee, diversion means pre-charging, and it's roughly a 6-month program. It's a hands-off for our low-risk individuals. If they successfully complete it, no charges are filed. We have a deferred prosecution program as well. These are post-charge, and their plea is stayed until the program is successfully completed, roughly 6 months, and it may include community service, restitution, or cognitive behavioral programming. Our drug treatment court is for our high-risk individuals, most of them facing a prison term, and that's for between 12 and 18 months. Same with the Veterans Treatment Initiative. We also have an extensive pretrial supervision program, which involves everything from a hands-off approach and automated court reminders to weekly check-ins with a case manager. None of these programs that we already had in existence specifically focused on our mental health population, which we estimated was between 30 and 35% of our incarcerated population was on psychotropic meds. So when the Safety and Justice Challenge opportunity came along, it was clear that the mental health population was a group we wanted to focus on. No one wanted that group in the jail, from the public defender, the district attorney, the sheriff, pretrial courts. Everyone recognized that the jail was not the right place for this population. We were inspired by what Judge Leifman and Miami-Dade were doing, and we took that example and tried to make one ourselves. So our goal in Milwaukee for the post-booking stabilization was to create a process to divert individuals with mental health conditions from the jail to community-based support services. The benefit would be to connect individuals to treatment, and now we had to build that entity, as the chief mentioned. The criminal justice system had a strong working relationship with all of our partners. However, we had to further expand and build our relationships with behavioral health and our housing division. Everyone agreed this is what we needed to do. It was just coming together, and as people have mentioned throughout the day during these sessions, everyone has a different language and different definitions of risk, so it took us a long time to get on the same page addressing risk and what needed to be done. Risk for criminal justice and pretrial is one thing, risk in behavioral health is something else, and so we were talking past each other for a long period of time. We finally have that resolved, I think. There was a group of the district attorney's office, the public defender's office, the courts, pretrial, behavioral health, housing, and the Community Justice Council, along with our corporation counsel for the county and the jail, met weekly for about a year to develop our post-booking stabilization map. In May of 2017, we launched our pilot project, which was really in-kind services from the various entities to make sure our map and conceptually our process worked before we went live with it in September. So this is a cleaned up version of our map, because the actual one is very convoluted. So we agreed initially that we were going to focus on the population that was booked into the criminal justice facility. That's our local jail, because it was an easy spot for us to identify because we had a universal screening already in place. We added in April of last year the brief jail mental health screen to our universal screening process. Because of the Safety and Justice Challenge, we hired 3 community intervention specialists, so the CIS workers. They're actually located in our housing department or division because we were under the impression that housing was a huge issue for a lot of these individuals, and they would know the resources and connections available. So every morning, a CIS worker logs into our secure portal where all of our pretrial assessments are listed and creates a list for individuals who flagged as possible on the brief jail mental health screen. That list is then sent to a small group with the assigned assistant district attorney and PDs for review. The assistant district attorney reviews these as far as criminal history, current charges, and makes the necessary victim contacts. While that's happening, the public defender is also looking through these, and the CIS is also looking to see if these individuals on the list may have community connections already that kind of lagged or need to be brought back up. Once the ADA decides that someone is appropriate for the program, she contacts our public defender and our CIS worker, who meet with the individual in our central intake unit in the jail. Those two individuals explain the program, it's voluntary, and they also get them to sign a release agreement so all of their information can be shared between the appropriate parties. We've also recently added a community assessment and recovery support assessment by a BHD clinician, which helps us to better match up community services and supports in the community for when the person is released from custody. Once all of that has taken place, the district attorney writes up an agreement, hopefully pre-charging, and also then requests the individual's release from jail. The individual is released to the community intervention specialist, so it's a familiar face to help. They're still, struggling, so we thought a familiar face, and then they physically transport them to wherever it's decided, whether it's their housing location. We have post-booking stabilization housing, which has 2 different houses, has a total of 6 beds, and other places, whether it is out at the behavioral health complex for treatment services or if they can go home, so wherever it is already decided. And then our PBS team meets weekly for staffing to review participants. So the PBS team consists of the assistant district attorney, the public defender, the CIS workers, and then also treatment providers when they are able to attend. And we also have a CART team, a crisis assessment response team, which is law enforcement and a clinician who also may attend as well. So this is the brief jail mental health screen. It was discussed earlier, so it's a simple 8 questions. It's added in. It's done by our pretrial supervision agency, which is a contracted provider in the jail. Going back to the staffings, all of the parties, it's a collaborative effort, and it's described, one of the attorneys described it as a brainstorming for success opportunity. It's really looking to try and figure out what else can be done to help the individual succeed and be successful, and recognizing that success and stable means something different for everyone that's involved based off of their situations. So it's looking at individuals who are struggling and what needs to be done to help them, those that are doing really well and maybe coming up close to discharge, and individuals that may be entering the program. There's an administrative group that meets every 2 weeks that reviews bigger problems that may have been addressed as far as the big picture of post-booking stabilization and different issues or processes that have been, roadblocks that may have been discovered by the weekly staffings. In conducting the brief jail mental health screen, we've realized that roughly 27% of the individuals flag yes on this tool, so it matches pretty closely with our 35% in the jail on psychotropic meds. So we felt pretty confident, we're comfortable with those numbers at this time. So this is the racial makeup of the individuals enrolled in our program. Since it started in September, our N is really small still, but it mirrors that racial makeup of those incarcerated for the discharged and for the currently enrolled. Everyone in Milwaukee is well aware that our incarcerated population does not mirror that of the county, so that's just another topic that we are working to address. The participant age, as I mentioned, our N is really small, so this is as of June 1st. We had 67 individuals currently enrolled, and then 52 had been discharged, so the age of the program. One of the issues that we've had to address is in Wisconsin, 17 is an adult in the criminal justice system, but that's not the case for behavioral health and housing, it's 18. So when we have young individuals, it causes a little bit of a resource overlap struggle. There are various levels of care. These are provided through our behavioral health division, through contracted service providers. It just shows the various acuteness of them. So these are what all of those acronyms mean. Our CSP and CCS, so community support programs and comprehensive community services, are our highest level of care, and those represent the majority of the individuals in our program, between 17% and 12% respectively. So of those that have been discharged, 58 were discharged successfully, which means no charges were issued. 25% were discharged for noncompliance. They didn't meet their agreement conditions or requirements, or they may be MIA. 4% 4% have transitioned to either our drug treatment court or we have a small mental health pilot as well. So they just maybe or they could have gone to our deferred prosecution. So there was a little bit more that was provided to them. As I mentioned, it's a voluntary program. So some just declined after they entered. And then there are a few that declined for other reasons. When we were developing the program, we went back and forth on as far as how long the program should be. The public defender's office wanted it to be 2 months. The district attorney's office was really pushing for 4 to 6. Our average is just shy of 4 months with everyone in this. We were looking at various reasons for the discharge and why they're being discharged. So even though it's a small number, we do have some very preliminary information on successful completions by the length of time in the program, successful completions by who their community intervention specialists are, and successful completions by the community service provider as well, although since our population is still so small, we're just collecting it at this point and no conclusions can be drawn from that. We continue to work through all of those issues. So our next steps are just to continue the learning process. We're also adding peer supports. That's been a huge push, and we have them in all of our other programs for early interventions, but recognizing that it would be really helpful for this population. So that contract is currently out for signatures to include those. We're also looking at adding a pre-booking population, so for individuals who are arrested and taken right out to behavioral health instead of down to the jail, but they may have a police hold, which inevitably means they're coming to the jail, so catching them even before that. We're also looking to streamline and expedite the referral and release process, although we average roughly 12 to 14 hours saved for individuals that are admitted into post-booking to those similarly situated and released through our normal criminal justice process. We also are increasing the utilization of our CART team, which I mentioned pairs a BHD clinician and a law enforcement officer. They're adding more CART teams throughout our county as well, so those have been helpful. And then just figuring out how to develop our sustainability. Under the grant, it funds the 3 CIS workers and a public defender and district attorney as well. So just figuring out how to keep everything going and recognizing it looks promising, but it's still really new and still really young to make any full conclusions.
Great, thanks to all our presenters. Fantastic presentation. So we're going to do questions and answers now. If you have a question, please raise your hand and a microphone will be brought to you.
Hi, this is for Milwaukee for the post-booking stabilization program. What charges are eligible for that?
We haven't said any are ineligible, so there are individuals that are in the program with arson, but a lot of them are disorderly conducts or type of battery where it's not not very violent. We did follow our early interventions policy, which does have some exclusionary ones, but it's much more flexible and reviewed on an individual basis. So it depends as far as if it's battery, how extreme it was.
Once you get them in the system and they are mentally sick, what do you do the next time they're in jail? You don't have to go through the same process, so what do?
Every time they're booked in, we screen them again. That's based off of our pretrial protocol. So they could be readmitted into the program. Other times it's realized that they may not be a good fit. Their acuity may be too much, and so other routes are taken with them.
Now, with experience we have in our parish, which is, we got a parish instead of a county, Ascension, but a lot of the mental people, they don't want to take their medication. So how do you deal with that? I mean, you can't make anybody take medicine.
Yeah.
Well, the mentally ill intersect with us in different divisions of our court. They are all over all of the divisions of our court, including the civil division. And even there, the law does not allow you to take them without their will unless they are a threat to themselves or a threat to someone else. So you're right, there are some people. A lot of people come in are seriously mentally ill and their behavior is extreme. So we have screened out a lot of people that need mental health. But this team of executives that oversee how we're doing and what we're doing and why have voices at the table at the executive community meeting as well as our council meetings. And those are questions that we always ask. You know, are there other places, are there other support that we can get for people who don't really fit the profile that we think we can manage?
If I may add, stable housing is the key.
They can't hear you. You have to pull it up to us.
How's that? Stable housing is the key to making certain that people stay on their medications. If you have sustainable, supportive housing that can assure people who are leaving the justice system in whatever fashion that they do maintain their regimen of medication.
Ms. Garbo mentioned that we have a pretrial public safety assessment tool. I pay about $5 million plus to 72 people who follow everybody around. That's a substantial thing that helps the council feel confident that the public will feel safe if people are discharged for care or discharged because they should be free pending trial. We have a community that we have to speak to about what we're doing and why and how can we keep that command of public safety first and foremost, just as the caretaker function that we. So our system probably works as well as it does because we spend a lot of money pre-trial. And we don't have a bail system like most states. Our Constitution says that cash is only required if there's a likelihood that you will not reappear for your court date or you are likely a risk of public safety. And with our assessment tools, a significant number of people who are arrested are released pending trial, even if they're not in our special programs.
Great. Hello, my name is Alma Castro. I'm with the City of Long Beach, and we're within Los Angeles County. We're the second largest city in the county. And we're unique because we have our own police department. We're not part of LA Sheriff. And we also have our own health department, which has led us to form our own justice lab. Out of curiosity, within your counties that have an independent functioning jail like we do, but no one is there longer than 72 hours, what is that relationship and bridging between that early intervention point at a city level? If one does exist.
Well, I can speak for our community. We have a local jail, a county jail, and a lot of our focus is intercepting prior to booking in the jail, not unlike Milwaukee County. And so maintaining a close relationship with our nonprofits and actually having places to send people to that are an alternate to the booking room in the jail is critical to making certain you can divert people from the criminal justice system. Does that come close to answering your question?
Because we're looking at what can we do within the city of Long Beach before someone even goes to county jail,
Absolutely.
right? So we're looking at we're working with our city prosecutor for a priority access diversion program, pre-arraignment. And then we also formed a multidisciplinary team that is very much like the governing and weekly body that looks at service coordination for our highest utilizers for low-level offenses.
In Milwaukee, if you're brought to the jail, for misdemeanors it's 48 hours and for felonies it's 72. Within the city of Milwaukee, we used to have a really strong community prosecution unit, and so if they were brought into district stations, they would be released and reviewed a lot faster, potentially, than they would never actually make it down to the jail. But once you're in the jail, you have to have a review and a first appearance within 48 or 72, depending on what you're brought in on. But there are a lot of individuals who have got out even before that as well. It doesn't really answer.
Right. We only have 3 levels of courts in 72. We are general jurisdiction state trial courts sitting in the counties. And we also oversee the municipal courts who only hear ordinance cases. So our court system, even though we call them county courts, it really is the only, and county jails is really the only game in town. And the hours only mean that I have to have a staff to see and hear the public defender and the DA with the person before a bail decision is set. The 48 and the 72 hours, that's the only relevance.
This is Sarah Peterson, Cottington County. My question is for Hawaii. Can you talk a little bit more about, I'd say your name, but I'd mess it up. Can you talk a little bit more about, you talked within your program about assessing readiness for change. What does that look like for you guys? Are you meeting with that individual weekly, daily? Can you give more details to that, or do you have a certain format or questions that you use for those individuals?
So we don't actually use a specific tool. Based on our experience with our outreach workers, and specifically targeting some of the more severely mentally ill folks, some of these folks are very, very slow to change, and some of them are quite, anybody who's done street outreach knows that a lot of times when the people you want to help the most are the ones that are going to yell at you or tell you to get away or be kind of hostile towards you. So it's mostly those folks, building rapport with them, and clearly when they're the first 5 or 10 or 20 times that you see them, they're not going to want anything from you, or maybe not even want to talk to you. But over the ensuing time, you can determine whether they're willing to go get a cup of coffee with you, or want to sign up for benefits with you, or have the infected toe underfoot looked at by one of our nurses, and so and then further on down the line, we can assess things like their willingness to take medications, and that's where the opportunity to provide a kind of unique tool like a long-acting injectable medication has been transformative to some of our patients. I don't think there are too many teams in the country that do shots in the community, on the sidewalk even, and some of those processes of readiness for change in terms of medication are what we've been looking at quite strongly in recent months.
Do we have any other questions?
This is a question regarding the tiny houses, villages. How, given a population of people that have a lot of challenges and often a lot of mental health and substance abuse challenges as well, what kind of parameters do you put in place to not just create another unhealthy living situation on a kind of an aggregate level?
Thank you. We have a continuum of housing along the continuum, which begins with the emergency freezing night housing and goes all the way to home ownership. Most of the steps along the way do not allow criminal activity or substance use inside of the perimeters of the housing unit, whether it be a shelter or a village. The active users are and will be housed in housing first, or wet bed housing, which has a 24/7 staff who are capable of crisis intervention, and they keep the goal is to keep the crises inside the perimeters of the living facility. Therefore, it doesn't move into the surrounding neighborhoods, which is always a fear. So the issue with the low barrier housing is that the people who are ineligible, people who want to take their drugs in there with them, for instance, they don't have a place to go. And that is really the crisis that we have at really every city and every county level, is that what happens to the people who are not eligible for the safe and secure housing that you're trying to provide until you have enough of the wet bed or crisis-related housing. Well, we don't, and that's the direction that we're going. In the meantime, I think everybody in the room will acknowledge we do have an issue with that. That issue is running rampant. And by adding wet bed housing, we do take a step toward addressing that, but it's a very slow process.
Great. Well, let's give our panelists one more round of applause.